अच्छा अब मैं दोबारा
बिल्कुल दोबारा से start करें।
ओके
ठीक।
Good morning students. Again an online lecture without my face. So it's cholelithiasis, and so we are discussing with the gallbladder diseases, and the most common is the cholelithiasis. If you have any query or question, you can put it in the end in the form of question, and I will answer all queries with separate lecture. Now we have to discuss with the anatomy of the gallbladder. It is a pear-shaped structure and it lies beneath the liver at the junction of the right and left lobe of the liver. It is about 10 centimeter long and it has a capacity of more than 30 ml. Now anatomically it has three parts: fundus, body and neck. So the muscle fibers in the wall of the gallbladder are arranged in a crisscross manner, especially at the neck, and that gives the appearance of a sphincter. There is no definite sphincter, but it gives the appearance of a sphincter. Now cystic duct is a continuation of the neck of the gallbladder. It is 3 centimeter in length with 1 to 3 centimeter lumen, and mucosa of the cystic duct arranged in the form of folds and act as a valves, and these valves are known as valves of Heaster. Wall of the cystic duct is surrounded by the sphincteric structure called the sphincter of Lucan, and that is the basic sphincter which holds the bile, and whenever there is a need of the bile, it will get relaxed due to the different enzymes secreted, and bile comes into the duodenum. So it means gallbladder work as a storehouse. Now when we as a surgeon offer cholecystectomy to the patients, patient says कि जी पित्ता निकल गया, then हमारा क्या होगा? Then you have to explain to the patient that gallbladder itself has no job. It is only the storehouse for the bile, and it make the bile more concentrated, and on demand, on need, it will supply bile. But when there is no gallbladder, then liver itself will produce bile on the demand. Now that cystic duct unite with the common hepatic duct. Now common hepatic duct is formed by the right and left hepatic ducts, and then that common hepatic ducts after union with the cystic duct becomes the common bile duct. So common hepatic duct is a 2.5 centimeter long, and it is formed by the union of the right and left hepatic duct, as I told. Common bile duct is very important for the surgeon. It is 7.5 centimeter long, and it is formed by the junction of the cystic and the common hepatic duct. Now this is the diagram where you can clearly see the gallbladder, cystic duct united with the common hepatic duct form the common bile duct. Now you see the common bile duct has a portion above the duodenum, portion behind the duodenum, portion below the duodenum, and portion inside the duodenum. So in this way, this common bile duct divided into the supraduodenal portion, retroduodenal portion, infraduodenal portion, and the intraduodenal portion. Now this is very important for the surgeon. Now what is callous triangle? Now callous triangle is again very important landmark for the surgeon when surgeon performs the surgery on the gallbladder. Now it is bordered by the cystic duct inferiorly, common hepatic duct medially, and the superior border of the cystic artery. Important surgical landmark, why it is important, should be identified by the surgeons performing cholecystectomy to avoid damage to the extrahepatic biliary system. Now coming to the topic, what is cholelithiasis? So cholelithiasis is the gallstones in the gallbladder. Most common biliary pathology affect almost 10 to 15% of the population. Usually it is asymptomatic, that is in 80% of the cases, but sometimes asymptomatic patients also require surgery. In good olden days, they says that the symptomatic gallbladder requires surgery, but now when we are seeing many complications related with the asymptomatic gallstones, I always suggest whenever there is a stone in the gallbladder, you have to take it out before it produce complications to the patient. So it makes cholecystectomy one of the most common operations performed by general surgeon. Now these are the multiple gallstones. You can well see if gallbladder perforate. These all stones comes into the peritoneal cavity. Now there are different types of the gallstones. Three types more important, that is cholesterol stones, pigment stones and mixed stones. Mixed stones you contain calcium, bile pigments, phospholipid, everything. And pigment stones mainly present in those patients when there is more hemolysis, and these are greenish black. And you must listen that the females, fatty patients above 40 years of age have more chances of the gallstones. These are basically cholesterol stones, contains mostly fat or cholesterol. So same incidence, 5 F's you have to remember, that is fat, fertile, flatulent. Flatulent means patients who are having distended abdomen, gaseous distension, females of 40 or 50 years of age. But it can occur in both the sexes, so males also having cholelithiasis, quite often in early ages, even in the childhood. And when in childhood, you must think of the congenital disorders related with the hemolysis. More common in old ages. There are multiple factors related with the formation of the gallstones. They are common in the western countries and northern India. Now, what are the causal factors in the formation of the gallstones? Now, pigment stones contain less than 30% cholesterol. These are two types of the pigment stones, black and the brown. Black stones are insoluble bilirubin pigment mixed with the calcium phosphate and the calcium bicarbonate, and they make 20 to 30% stones, and incidence rises with the age. Black stones are associated, as I told, with hemolysis, usually hereditary spherocytosis, sickle cell anemia, and so on. Now, patients with cirrhosis have a higher incidence of pigment stone formation. Now, brown stones contain calcium bilirubinate, calcium palmitate, stearate, and cholesterol, of course. They are rare in the gallbladder. They are mostly formed primarily in the bile duct, also associated with the presence of the foreign body with the bile ducts, such as parasites like Ascaris lumbricoides. They try to produce brown stones there. Now, this slide is showing factors associated with the gallstone formation. Now, there is an impaired gallbladder function. It means the gallbladder is unable to empty it properly, absorb or excretion related. Supersaturated bile means age, sex, genetics, obesity, diet, means bile is containing more cholesterol. Cholesterol nucleating factors, mucus, glycoprotein, infection, or absorption, enterohepatic circulation of bile salt acids is in the problem. Now, deoxycholate, bowel transit time is high, fecal enteric flora is not there. There is an ileal resection, which is known as small gut syndrome, and in small gut syndrome there is a malabsorption and cholestyramine. So, what are the effects of the gallstones? Now, when they are in the gallbladder, as I said, they are mostly asymptomatic, so known as silent stones. 10% of the males and 20% of the females, silent stones. But there are many stones which causes problem. Now that problem is biliary colic, and this whenever there is a colic, it is always means periodic pain. It comes and wanes, so waning and vanishing. So present in 10 to 25% of the patient, severe within an hour after meals. It may be dull and constant, spasmodic pain, severe in nature. In right upper quadrant and epigastrium, it radiates towards chest and shoulder, and sometimes it mimics with the cardiac pain also. Generally starts at night, wakes the patient up from the night sleep, precipitated by heavy meal. When this gallbladder becomes infected, patient may have fever and increased WBC count may be observed. So it means there is a formation of pyocele or empyema gallbladder. Now when this stone, when there is a big stone, it will stay in the gallbladder because of the sphincteric mechanism at the Hartmann's and the neck of the gallbladder. But when there are small stones and multiple stones, they may come into the common bile duct. So common bile duct have usually secondary stones. It means primarily formation of the stones in the common bile duct is rare, but they come from the gallbladder and causes cholangitis, pancreatitis, Merz's syndrome. That is, what is Merz's syndrome? Already I talked in the obstructive jaundice also, that compression of the common hepatic duct or common bile duct by the stones from the cystic duct or Hartmann's pouch. And when they block the common bile duct, patient present with the jaundice, which is the most common complication of the gallstones, that is the cholelithiasis. So jaundice may result if the stone migrates from the gallbladder and obstruct the common bile duct. So this jaundice pattern is the obstructive jaundice. And when that stone comes in the intestine, from where it comes, either by Merz's syndrome, there is a formation of the cholecystoduodenal fistula, and that stone comes in the intestine and cause the obstruction, and that intestinal obstruction is known as gallstone ileus. So when you will discuss the intestinal obstruction and the causes of the intestinal obstruction, so one of the causes is the gallstone ileus, and everybody is astonished from where gallstone from the gallbladder comes to the intestine. So it is by the formation of the fistula. So patient present with the biliary colic, with acute cholecystitis, chronic cholecystitis, gallstone pancreatitis, a very lethal complication, obstructive jaundice, again a lethal complication, acute cholangitis, gallstone ileus, mucocele or empyema of the gallbladder. Now if we talk about the biliary colic, it is episodic pain in the epigastrium, radiates to the lower pole of the scapula on the back side, and patient may suffer from the sweating, nausea, vomiting. And in this case, biliary colic, there is an intermittent jaundice with pale stool and dark urine. It means a stone comes in the bile duct, block the bile duct, and then it passes. So this is known as intermittent jaundice. Now differential diagnosis of the biliary colic is the renal colic, intestinal obstruction, angina. As I told, it mimics with the cardiac pain. Pain episode may resolve when stone is passed into the common bile duct or when stone falls back into the gallbladder itself. Now acute cholecystitis, severe constant pain, localized in the right hypochondrium. Patient may have fever, toxemia, rigors, leukocytosis, tenderness in the right hypochondrium, Murphy sign, palpable gallbladder. Now what is Murphy sign? When you ask patient to take deep breath and press the costal cartilage at the tip of the ninth costal cartilage, patient will catch hold his breath on the peak of the expiration. Chronic and mostly Murphy sign is the indication of chronic cholecystitis. In acute cholecystitis, patient is already tender in the right hypochondrium. So if you try to perform Murphy sign in acute cholecystitis, patient will cry. So don't do that. Repeated inflammation resulting in fibrosis and thickening of the gallbladder, and long-standing dyspepsia with episodic cholecystitis. Now differential diagnosis for the chronic cholecystitis, peptic ulcer, hiatus hernia, and again angina. Now what are the complications further on? As I told, formation of the empyema. Empyema is the pyocele. Now before pyocele there is a mucocele. There is a blockage of stone at the neck of the gallbladder, and there is a presence of bile in the gallbladder, presence of the bile in the gallbladder, which first there is an absorption, and later on due to stasis of the bile there is a proliferation of the bacteria resulting into the pyocele and the empyema. Now that gallbladder may perforate or that stone may go to the common bile duct, as I told, causing obstructive jaundice. Now sometimes there is an acalculous cholecystitis also. Now what is acalculous cholecystitis? Means same cholecystitis, but when you do ultrasound there is no stone. Now acalculous cholecystitis is common in typhoid carriers or in diabetic patients. Now what is Murphy's sign? As I already explained, in acute phase the patient may have right upper quadrant tenderness that is exacerbated during inspiration by the examiner's right subcostal palpation. Minor episodes of same discomfort may intermittently during the day. Dyspeptic symptoms may coexist and may be worse after such an attack. As pain resolved, patient improve. Now other symptoms, again it's a repetition. Why it is repetition? Because these symptoms are very important. Dyspepsia, if somebody is coming with dyspepsia, not responding to the proton pump inhibitor, you have to do ultrasound and you may get the stones in the gallbladder. Food intolerance and alteration in biliary frequency. Now the investigation of choice is the radiological investigation, that is ultrasound, and ultrasound can show you not only the gallstones but all the some signs of the acute cholecystitis, that is gallbladder wall become thick, there is a stone and there is a pericholecystic fluid. Well, you can well see in this photograph. What is gallstone pancreatitis? Due to transient blocking of the ampulla of water by the stone, especially when stones are small and numerous. And now you see, public thing, if size of the stone is big, it is dangerous. But we as a surgeon know that whenever there is a small stone, it is more dangerous. Why? Because small stone may migrate to the common bile duct, may come to the ampulla of water, may go to the pancreatic duct and causes the pancreatitis. Obstructive jaundice, in this case acute in onset. Now you have to differentiate obstructive jaundice because of the gallstones or because of malignancy. That's why I am saying that acute in onset means it is most of the time related with the cholelithiasis. Patient is having previous history of pain in the right hypochondrium, and in this case gallbladder will not be palpable. Now what is Courvoisier's law? It states that in the presence of the palpably enlarged gallbladder, which is non-tender and accompanied with mild painless jaundice, the cause is unlikely to be gallstone. Now it means causes the malignancy. Now in malignancy there is a progressive jaundice, so you get the palpable gallbladder but without tenderness. Acute cholangitis, infection of the bile duct, are usually caused by the bacteria ascending from its junction with the duodenum. So tends to occur if the bile duct is already partially obstructed by the gallstones. And now in this patient will be having fever and jaundice. So there is a Charcot triad that is saying if patient is having jaundice, fever with chills and fever with chills and the pain in the right hypochondrium, that is known as Charcot's triad. Now what are the predisposing factors? Stone in the common bile duct, biliary stricture, so small stone may cause complete obstruction, or sometimes post ERCP. Why post ERCP? Post ERCP you may damage pancreatic duct or bile duct and resulting into the edema and obstruction. Post biliary reconstructive procedures also. Now treatment is antibiotics and resuscitation followed by decompression of the biliary tree. Gallstone ileus, obstruction of the small bowel by a large gallstone. Symptoms is vomiting, abdominal pain, distension. Now these are the cardinal features of intestinal obstruction. Patient will be having vomiting, pain in the abdomen and distension of the abdomen. Now in signs you will get distended abdomen with exaggerated gut sounds, which is also known as obstructive bowel sounds, and treatment is laparotomy and removal of the stone from small bowel. So we discussed about the cholelithiasis and its complications. Now for the diagnosis of cholelithiasis, of course, first you have to have a very good history, physical examination, and then you confirm it by doing certain blood tests, radiological tests, and so on. So radiological studies is the ultrasound or radionucleotide scan. A positive Murphy sign suggests acute inflammation. Now in blood you will get leukocytosis, and when you do the liver function test, if it is an obstructive jaundice, you will be having increased level of the alkaline phosphatase and gamma GT along with the total bilirubin and direct bilirubin. But if it is only acute cholecystitis or chronic cholecystitis, you will not get any changes in the liver functions. So what investigation you will advise? Of course, ultrasound is the investigation of choice. Plain X-ray. Now gallstones are, majority of the gallstones you cannot see on the X-ray, but 10 to 20% gallstones you can see on the plain X-ray. This is reverse of the renal stones. In renal stones, majority are visible on plain X-ray, only 10 to 20% are not visible on the plain X-ray. Liver function test, CBC, in which WBC count you will look for. Now CT scan abdomen is important to exclude the other causes of the obstructive jaundice like malignancies. And treatment, of course, is the laparoscopic cholecystectomy or open cholecystectomy. Now this is the ultrasound again, single large stone causing acoustic shadow, multiple stones. This is the plain X-ray. This is not the ultrasound. Now in this X-ray you can see radio opaque stones in the gallbladder, and this is only, as I said, in 10 to 20% of cases. So treatment, patient with asymptomatic gallstones, safe to observe the patient, or it is better to do cholecystectomy. Patient who develops symptoms or complications, treatment obviously is surgery, and that is cholecystectomy. Prophylactic cholecystectomy sometimes you can do when there is a risk of developing symptoms is increased, and it may be done in the patients with diabetes or congenital hemolytic anemia. Why in diabetes? Because diabetic patients have less pain perception. So patient may develop acute cholecystitis, but patient will not be having pain. So in diabetic patient, even in asymptomatic stage, go for the cholecystectomy. In congenital hemolytic anemia, always chances of formation of the multiple pigment stone, so better to do the cholecystectomy. Acute cholecystitis treatment is conservative treatment. Now here there are two schools of thought. One type of surgeons say patient comes within 24 hours with acute cholecystitis, you can go for the surgery. Second school of thought, in acute cholecystitis, first give the conservative management and then do the interval cholecystectomy after 6 weeks. So now depends, conservative treatment depends on 4 principles. Nil per oral. It means when patient is having continuous vomiting, you cannot give oral, so you have to give IV fluids until patient having no pain or no vomiting, and then giving the analgesia, administration of antibiotics. If cystic duct is blocked, in most cases concentration of antibiotics in serum is more important than its concentration in the bile. So broad spectrum antibiotic is more effective against the gram-negative bacteria, for example gentamicin, cefazolin or ceftriaxone. Now there are many side effects related with the gentamicin. So presently the antibiotic of choice is the second generation cephalosporin, that is ceftriaxone. So how you prepare the patient for the cholecystectomy? You have to do full blood count, renal profile, liver function test, coagulation profile, chest X-ray, ECG when patient is more than 40 years of age, antibiotic prophylaxis, deep vein thrombosis prophylaxis, and you have to take informed consent. For the laparoscopic cholecystectomy, same preparation, and you just know few important points regarding laparoscopy. That is, you have to put laparoscope first port by open technique, means you will see and then you will put the port. This the insertion, and what are the keys important? 4-port technique. One is for the camera, one is for the dissection, and 2 ports for the retraction. So when you put the ports, you produce the pneumoperitoneum by carbon dioxide. First thing is you have to identify the callous triangle for the safe dissection. For patients whom laparoscopic approach is not indicated, you can go for the open cholecystectomy, or if you started with laparoscopic approach and due to adhesions or edema you are unable to continue the laparoscopic approach, you can convert it to do an open cholecystectomy. Now for the open cholecystectomy, the incision you give is the right subcostal incision, which is also known as Cocker's incision. It is given into the right hypochondrium, 2 finger breadth below the costal margin. It is known as Cocker's incision. You can see the number of stones. Wow. So now first we discussed the complications of stones itself. Now complications of cholecystectomy. Early biliary complications, you can have a bile leak, hematoma, abscess, any dropped stone in the peritoneal cavity. Now late biliary complications, when symptoms persist, biliary stricture comes in the mind, and there is a port site hernia. From where you put the port, there are chances of the hernia formation. Thank you very much. कितनी देर लगी?
Ma'am, exactly 25 minutes.